few minutes for questions. If folks do have questions, if they would step to the microphones and identify yourself as you ask your question.
My name is Eduardo Sanchez. I serve on the roundtable. I work for the American Heart Association. Tom, good to see you.
I see you, Eduardo.
This is a question comment to Dr. Stockman, and I appreciated all of the presentations. I think they were very illuminating. As it relates to cross-sector collaborations, do you know of any examples where Medicaid is partnering with WIC at the state level, taking EPSDT and connecting those individuals and those families that might benefit from the counseling that probably ought to go with children with overweight and or obesity? And anything that you can say about those collaborations, if they exist, would be great.
That's a great question. I have heard that they do exist, but I cannot speak with much authority specifically about them. But there should be more of them, so that I hear more about them, and I could speak more authoritatively about them. What I can say is that most of my job is working with state Medicaid agencies to foster collaborations with their state public health and other partners. And WIC hasn't been a key part of what I have done recently, so I don't know as much about it in the forefront of my mind, but would be an essential partner because meeting people where they are already coming, where they're already coming to receive benefits is absolutely critical and is going to help get people connected to the services that they need. So I think I know that there are some examples of it. I can't unfortunately provide many details, but there need to be more, and we'd love to do what we can do to promote more of those types of connections to really meet people where they are. Thank you for the comment.
Ted?
Ted Kyle, I'm a member of the Roundtable, and I want to thank the panel for really outstanding presentations all around. And Bryce, your presentation really was quite interesting and provocative. And I'm wondering, with your embrace of the DPP, what you've seen in terms of uptake of it. There was a paper published recently that said for the CMS benefit on DPP-like intensive behavioral treatment, the uptake has been 0.6% or something like that. I'm wondering if you see anything better. And secondly, what your thoughts are about the fact that I read recently that half or more of the population of California now has prediabetes, and what sort of opportunities that presents for prevention via obesity care.
No, absolutely. Great question. So really quickly, we're still early in our diabetes prevention plan initiative. We just launched it January 1st. But what we're actually seeing is more interest than we actually expected. Where I think we're seeing it come from is primarily because we launched not only a brick and mortar network, but we launched a digital network as well. So we're seeing a lot of interest in the digital product, and I think there's a lot of research still to be done on whether the digital products can replicate the DPP results. But members offered a choice are opting strongly for the digital product, and I think that's driving a lot of our uptake. And you're exactly right. Even with our lower population health burden, we have plenty of opportunities, whether it be diabetes prevention or other things, to really ramp up our game in the prevention realm as well as the treatment realm. Omada is not in our network, but they are a digital provider.
Sean Lucan, Albert Einstein College of Medicine in the Bronx. So my research is on food environments and how they influence obesity, but I'm also a family physician. I treat children and adults. And what I've found is that there are explicit set criteria for referring patients into bariatric surgery and ultimately getting that surgery covered. But the same kind of criteria don't exist for prescribing pharmacotherapy. And I've had I think I've only rarely been able to get patients anything but metformin, whereas getting patients medications for their diabetes, hypertension, dyslipidemia, or weight-related issues like respiratory symptoms, depression, arthritis does not appear to be an issue. And it seems to me like that is a disservice to patients and potentially to payers. I mean, it seems like there could be a real cost savings if we did a better job treating their obesity. So I'm just wondering if you could give your thoughts on that and why there's such obstacles to getting pharmacotherapy for obesity.
Sure. First of all, I'll admit that I'm the lifestyle medicine expert, not the pharmacotherapy or bariatric surgery expert. But I will say, in general, that Blue Shield recognizes the exact issue that you laid out, and are looking at both policies for pharmacotherapy and for bariatric surgery. I think historically the health plan perspective on both has been, I don't think it was ill-intentioned, but to set up a lot of gates and hurdles that people had to jump over. Where we're now turning our attention to is to say, yes, let's get some safety guardrails around this stuff, but there are a lot of well-intentioned providers out in the world, such as yourselves, who are really focusing on how to get the right medicine or the right surgery or the right lifestyle intervention to the right patient. And that's the dialogue we want to be having. We realize we're not there yet, but that's the direction we're going.
And I can probably respond to that. And I'm going to ask Dr. Yanowski to speak a little bit to the side effects. I think we're learning a lot. Certainly the data around bariatric surgery has changed over time. And the understanding of the medications has changed a fair bit, and I think there are concerns, for instance, about the side effects of some of the meds. So. Yes, please. There's one back over here.
Sure, when I was asked, well, do these medications have side effects, which I didn't have time to talk about in my lightning tour this morning, and I said, certainly they have side effects. Obesity has side effects, though, as well. And so for any medication, there's a risk-benefit analysis that has to take place. And I think the individual medications each has their own unique side effect profile. For example, phentermine can raise pulse and blood pressure. Lorcaserin can't be used with SSRI antidepressant medications. Topiramate and phentermine can cause increase in cleft lip and palate. So I think this is a very individualized process, and that's why patients need to go to their physicians who knows their medical history and what other medications they're on. And I think it's also why I mentioned that if patients aren't responding to a medication and some limited period of time with weight loss and with improvement in health, then it's a good idea to discontinue the medication because they're being exposed to those risks, but without concomitant benefit.
Thank you. I think, unfortunately, we are out of time. Apologize to those still at the microphone, and I'd like to really thank the panel for a great presentation.